So we're now going to make a big left turn and switch gears, mixing my metaphors, and we're going to hear something really exciting, an exciting announcement for the Institute, and also an opportunity to welcome a very special guest. So I'd like to invite Julie Bynes to the stage, Group Leader of Enteric Diseases and Head of the RV3 program. Julie, with her special guest.
Thanks very much, Andrew. Well, back in the 1970s, diarrhoea was a major killer of children worldwide. Like other major children's hospitals, the Royal Children's Hospital in Melbourne had a gastroenteritis ward, and for about 80% of children admitted to those wards, the cause of the gastroenteritis was unknown. At this time, Ruth Bishop was a microbiologist in the Department of Gastroenterology at the Royal Children's Hospital. She proposed that this unculturable organism causing gastroenteritis could be a virus. But identifying this infection had eluded scientists worldwide. It was through a collaboration that embraced clinical and scientific innovation that this challenge was taken on. Using a small bowel biopsy capsule fashioned from a cardiac catheter, the Director of Gastroenterology at the time, Raj Townley, took small bowel biopsies with the help of the gastroenterology fellow at the time, Jeff Davidson. And these were then examined under the electron microscope. This was new technology at that time at the University of Melbourne, in a team led by Ian Holmes involving Roger Snagel and Brian Ruck. From the first biopsy, from the first child, they saw small, round particles invading the small bowel lining. This was rotavirus. On identification of this particle and this virus, it was examined worldwide, and it was found that rotavirus was a major cause of severe dehydrating gastroenteritis worldwide. This discovery is acknowledged as one of the most important discoveries from Australia and contribution to global child health. Now that the cause of this diarrhoea was known, vaccines to prevent this infection were possible. Rotavirus vaccines have now been introduced in over 160 countries worldwide into their national immunisation programs. And this has resulted in a reduction in deaths and hospitalisations and absenteeism from school and for parents from work in many hundreds of thousands and millions of children over the past years since introduction. Today, MCRI has continued Ruth's work in an effort to reduce childhood diarrhoea. The RV3BB rotavirus vaccine, named after the developers Ruth Bishop and Graham Barnes, is now nearing introduction in Indonesia into the national immunisation program, hopefully next year. At MCRI, we have a lot to thank Ruth for, and certainly the world's children would join in those thanks. It is a great pleasure today to announce that the Bill and Melinda Gates Foundation will be acknowledging Ruth by funding a new fellowship at the Murdoch Children's Research Institute to be called the Ruth Bishop Fellowship. This fellowship is generously funded by the Foundation and will be worth $3 million over 5 years. We'll fund an outstanding mid-career female researcher in furthering Ruth's work in vaccine research. It will be supported by a generous research package. So why have we and the Gates Foundation specifically requested a female researcher? Well, Ruth was an exceptional role model to scientists worldwide. Born at a time when women in science were rare, who, through hard work and a little bit of luck along the way, was able to pursue her passion in science, and was at the same time able to balance her life as a mother of 3 and a wife of a successful but very busy obstetrician gynaecologist. Whilst there's no shortage of women in medical research, there continues to be a shortage of women at the higher end and leadership positions in research. This fellowship aims to support an emerging woman and give her the opportunity to enter and really consolidate her medical research and to make a real difference. I know Ruth would enthusiastically support this. I'd now like to invite Anne, Ruth's daughter, to come to the stage and accept the naming of the fellowship on Ruth's behalf.
Good morning, Julie, and everyone here today. On behalf of my family, my two brothers, Michael, who is here today, and Tom, who lives in Canada, I sincerely thank the Bill and Melinda Gates Foundation for funding this fellowship and the Murdoch Children's Research Institute, in particular Julie and Andrew, for their very hard work to make this possible. To those of you who knew her, and you would agree, she always encouraged fellowship and always advocated for her MCRI community. Today is a wonderful celebration of the collaboration of both. It is lovely to see so many of you here that were her colleagues for so many years, and hello to those who may be watching from afar. She would have thoroughly enjoyed this symposium. Mum wholeheartedly believed that when meaningful sponsorship meets research, change happens. Indeed, in her case, we can now reflect that exactly that happened and indeed saved millions of lives. Mum would be very humbled by this fellowship. But she would insist that her team members were also acknowledged. So can I use this moment to acknowledge all of you and say thanks on her behalf. But there is one very important person, Professor Graham Barnes, who is with us here today. Graham, you and Mum shared literally a lifetime of incredible and unique scientific collaboration and friendship. I recall hanging out as a teenager in the RCH gastro unit, watching rats and playing up, while you and Mum collated endless papers, submissions, presentations and recruitments. Thank you, Graham. As I said, Mum would be humbled that this fellowship is being bestowed by the generous and prestigious Bill and Melinda Gates Foundation. They've not only been a vital part in the delivery of the rotavirus vaccine, but they continue to enable a positive real-life outcome for global health. Mum held the utmost respect for the Gates Foundation, its values and its people. Nearly finished. While Mum didn't see herself as a trailblazer, she pioneered through decades where the effects of gender imbalance and disadvantage were obvious both in Australia and overseas. From a modest upbringing in Frankston, she gave us 7 decades of scientific persistence. She followed the science and listened to the people, not the politics. She broke through barriers with diplomacy and gracious determination, not division. She died last year on her 89th birthday. She was a brilliant human, compassionate, fair, diligent and humble. She was elegant, witty and wise, and very brave. She was a student, a colleague, a mentor, a wife, a mother, a grandmother, and a friend to the world. Ruth left her mark, but she refused to acknowledge that it was hers alone. It was always a team medal. She went out of her way to encourage and champion young minds. She would be thrilled that this fellowship will be going to a young female researcher, giving them every opportunity to continue the work, as she called it, and perhaps, as she did, change children's lives for the better. My family are looking forward to very much finding out who is recruited into this position, and we will be following their achievements with delight. Thank you all for the opportunity to speak for Mum today. On behalf of the Bishop family, we humbly and heartily approve of the naming of the Ruth Bishop Fellowship in her honour. Thank you.
Beautiful.
More than 20 years ago, Linda and I saw a newspaper article about the major causes of childhood death. One of the biggest killers was a disease called rotavirus, the leading cause of diarrhea. We asked ourselves why the world wasn't doing more to stop it. We soon learned that Ruth Bishop, an Australian virologist, had been asking that question long before us. In 1973, Ruth was the first person to identify rotavirus.
It was a very exciting moment to realise we had an answer. Suddenly, people, I think, were switching on their electron microscopes, having a look, finding it. The importance of it was established very quickly after the first discovery.
Her humble work focusing on this little-known disease helped pave the way for our foundation and Gavi, the Vaccine Alliance, to develop several vaccines that have saved the lives of millions of children in the world's poorest countries.
The rotavirus infection will be inevitable at some stage during everybody's life and probably repeatedly. But the purpose of the vaccine is to prevent that first infection being life-threatening in young children.
The Murdoch Children's Research Institute in Melbourne is continuing the work Ruth started by developing a rotavirus vaccine for newborns. Through her tireless research, Ruth has had a profound impact on the world, and many more children are alive today because of her.
Great. So we're now going to hop into a panel discussion. And thank you, Fiona, Amy, Farnaz, and Julie. And we're going to talk about the future of global health. So I'm very fortunate we've got experts on the stage, and I get to ask all the questions, and they get to answer. So in 2012, the world came together at a UN meeting in Rio to agree on the future we want and began a process to develop the SDGs, the Sustainable Development Goals. So there's 17 around people, planet, and prosperity. So there's been, as I mentioned, remarkable progress, but there's a lot more to do. And so the SDGs are threatened by climate change, war, as we're seeing at the moment, political oppression, economic insecurity, globalisation, the rapid development of digital technologies that are not necessarily equitable, and antimicrobial resistance. In 2018, the campus came together to develop a campus-wide vision for the future we want, and we developed Melbourne Children's Global Health. So this panel is now going to explore the progress towards the SDGs and how our approach at MCRI on the campus has shifted to address these issues. So, Fiona, immunisation is one of the most cost-effective and successful investments in global child health, and we've got vaccines for over 20 life-threatening diseases. But despite this, in 2021, 25 million children missed out on vaccination. So, Fiona, can you tell us about how we progress global equity around vaccines?
So it really is extraordinary that those statistics, those alarming statistics, are there, that so many children remain unvaccinated in 2023. We know how important they are. We know how important they are for morbidity, preventing morbidity and mortality. And we've known this for a very long time. So COVID has shed a spotlight on this in terms of vaccine inequity, but it has been such a long-standing problem, particularly for the poorest children living in the most difficult circumstances. These are the children that remain generally out of reach, and these children are the most at risk of dying and ending up with long-term problems, and they're also the children that can't access healthcare when they do get sick as well, so really very critical. In addition, these new vaccines that are coming, I mean, they're called new vaccines, but they're actually really old vaccines now. Pneumococcal conjugate vaccine, around for 23 years now. Still, only half of the world's children are vaccinated with pneumococcal vaccine. HPV vaccine, 15% of girls are vaccinated. Rotavirus, many countries still can't introduce that vaccine, particularly in our region, which is way behind. One of the main issues and one of the key issues is vaccine cost. So as more infections become vaccine preventable, it's really critical that we've become, particularly through COVID, how we can design and develop and get vaccines out there much more faster. And we've been incredibly good at that. But what we've been much less good at is making those vaccines equitable. Yep. And that's a really critical thing that we need to work on now. And I'm really pleased to be part of a call to action on vaccine equity in terms of making a call to action, really, to make fairer prices for vaccines for all countries, because really no country should be in a position where they cannot protect their children because they can't afford the vaccine.
Thanks, Fiona. So, Julie, we've been talking about the RV3BB vaccine, and could you tell us a little bit about your thinking about how to make it accessible and the right vaccine, I guess, for the region?
Sure. Well, when we started developing the RV3BB vaccine, it was not around just making another rotavirus vaccine. We wanted to develop a vaccine that was going to solve some of the challenges of implementation and to get a rotavirus vaccine out to more children. Doing that, we focused on some of the key gaps. Obviously, cost is one. And by partnering with emerging country vaccine manufacturers to make a large-scale vaccine cost-effective and affordable by low and middle-income countries was important. Other things such as providing the dose at birth, so capturing those babies before they leave the maternal, in contact with the maternal and child health worker, increases the opportunity of getting an immunisation, at least one, in before the baby is exposed to gastroenteritis. And the other issue is there are some other barriers to vaccine, and by partnering with Biopharma Indonesia, we're addressing the issue of making a halal rotavirus vaccine so it's socially acceptable and culturally acceptable in communities where this is an important issue.
Yeah, that's just fascinating because I'm not sure people would necessarily be thinking about that from the outset, so having that collaboration. So just building on that discussion around the collaboration informing pathways, maybe go back to you, Fiona, and just talk a little bit about how we can, we've got this long-standing, amazing relationship with Indonesian partners, particularly University Gadjah Mada. Could you talk about how we can build on that relationship?
Yeah, so, Julie's work and everybody's for the last 40 years, I think it's been, now, has been absolutely extraordinary, and also others such as, Kim Mulholland and his work in Vietnam and various places all around the world, and our work in Fiji and Laos and many other groups in the region. It's really a wonderful opportunity now to bring the wealth of experience that we have and the capability of doing vaccine research, and particularly the research that is then translated directly into policy, which is a lot of the work that we do, so that countries are able to make evidence-based decisions and be able to come together and to be able to share knowledge as well and shared experience, because a lot of the work that we do, so even though, for example, Julie's work is in Indonesia and technology transfer and things there, but the knowledge that comes out of that is for the world.
Yep.
And so similarly, a lot of the research questions that we develop, whether it's in Fiji or Laos or Vietnam, Mongolia, for example, is really at country level, to responding to country level questions, but really they're common policy questions across poor countries around the world. And I think bringing together that capability and sharing and having that sharing and networking so that countries can lead the research for questions for them and address, I think is really critical, and it was even more so in the pandemic that really shined a light on the lack of that and the real need for it.
Yeah, I think you're highlighting a successful model for the campus over a long period of time. So Farnaz, it's lovely to have you here with us.
It's good to be here.
So we've talked a bit about gains in child survival, and obviously with gains in child survival means more children are living through to adolescence. Mm-hmm. So as I understand it, as I'm told by many of my colleagues in adolescent health, we now have the largest cohort of adolescents the world has ever seen. So I have adolescent children, and I think they have huge potential. So could you tell us about your thoughts on the potential of this, the largest ever generation of adolescents?
Thanks, Andrew, and thanks for the question. Well, currently we have 1.8 billion adolescents in the world. That's more than the population of India, more than the population of China. So the numbers themselves are an enormous potential. It's just a huge, vast mass of energy and vitality. And at the beginning, when you mentioned these megatrends, climate change, economic insecurity, who's leading the response to all of those? It's young people. Who's holding us accountable for the world that they'll inherit? It's young people. So it's not only their numbers and their energy and vitality, but also their capacity to innovate. So if you think about innovation and creativity in the past, young people have been at the fore, but what we want to see as adolescent health researchers is not just a few of those 1.8 billion people innovating, but all of them. And that's really, when you have that vision in mind, then you've got hope for the future of the world.
Could you expand a bit on that positive message about how we at MCRI can facilitate and support that engagement of what seems like, you know, sort of a mind-blowingly large group of people?
Well, I think youth engagement and engaging them in health services is really critical because, frankly, Andrew, adults are boring. and health services are devised for, run by adults. And unless you've got youth engagement, they're going to disengage. It's just not going to lead to effective outcomes in them. And part of learning how to do that engagement, I think, will really shift the way we provide health services and have health systems. And not only just for young people, but for all people. So that's a really exciting area that the Centre for Adolescent Health is working on, because it's not as easy as it sounds. It's not a tokenistic engagement or a soundbite from a young person. That it's fundamentally shifting the way you give services. And one last thing to add is that this generation of young people rapidly changes. I don't know about I don't have adolescents, but I don't know about yours. But it's not an intergenerational change. It's changing quicker than that. So we really need to have our finger on the pulse of what challenges they're facing so that we can respond effectively.
Yeah, thank you. That was inspiring. Amy, so we're talking about hearing from adolescents, but I think what's critical to the way we work is hearing from our in-country partners in global health, the places where we work. So could you talk a little bit about our approach to how we work with our low and middle income country collaborators and what the sort of key principles are?
Yeah, I think it's really important to start with the fact that there's an ongoing and important discussion in global health about the need to decolonise the way we work in global health. And that's really shifting that centre of gravity in global health from what are often Western-based research institutes or other partners who may also have colonised countries to the countries and the contexts where the populations that we are helping are working and living. So I think that's something really important to acknowledge. One solution to that is this idea of localisation, and Julie's spoken beautifully about how to localise vaccine solutions, and I think Farnaz has just described how to localise that within the population that we care about. So how do we create local solutions by local people for local people and give them that power. Partnerships are really important, and long-term partnerships I think are particularly key to build that long-term understanding. I think it's also important to acknowledge that all partnerships are not necessarily equal relationships, so how do we make sure that we acknowledge our power balance or imbalance in those relationships? Our approach to this really in Melbourne Children's Global Health is, I think, turning towards thinking about that learning health system. So how do we help systems get their own data, generate their own research to get that data, use that data effectively, put it into practice, and then ask the next questions. And there's a few key principles around that. It's about supporting countries and people to lead and lead in a learning way. It's about supporting learning at different levels of that system, from the individuals to the patients themselves, the end users who have to teach us more than I think we teach them, through the organisations and the health systems we work in, and then it's really effectively using any data we get.
Yeah, and it's, I will say it's not easy, right?
It's not easy.
Not easy. But I do feel that MCRI and Melbourne Children's Global Health, we're up for the challenge, and there's a real momentum now to enable that local leadership and local capacity building. So I think we have come to time, unfortunately. I'd like to just close by saying to all of you, global health is everyone's business, and engage with the global health activities that are happening on the campus. And I'd like to also finish just by thanking Fiona, Amy, Farnaz and Julie for a really inspiring conversation. Thank you.
Thank you.
No time. There's a 1 minute warning.